Dear doctors, a very good morning to all of you. Thank you for joining today's webinar. Today is a very good day, Akshay Tritiya and Ramadan. So happy Akshay Tritiya and happy Ramadan to all of you. On behalf of DigiNeuro, digital initiative by Health and Youth Therapeutics, I warmly welcome you to this webinar. And Health and You is a pharmaceutical company in joint venture with Newlink Company Limited, Japan. Our mission is to fulfill unmet medical needs and we launch first time in India products to fulfill unmet medical needs. The first of its kind was Amnurite. First time amitriptyline plus mecobalamin combination was launched for diabetic neuropathy and migraine. So the benefit is once-a-day therapy in cost-effective manner. We were the first one to launch amitriptyline in 5 milligram strength. We are the only one who are importing mecobalamin injection made in Japan to give you the highest quality. We were the first one to combine amitriptyline plus propranolol when one drug is not enough in migraine. Amnurite beta, amitriptyline 5 milligram, propranolol 20 milligram extended release, amitriptyline 10 milligram and propranolol 40 milligram extended release. We were the first one to offer the first pharmacological combination in neuropathic pain of two neuroanalgesics. As you know, amitriptyline is once a day, but pregabalin is made once a day by sustained release technology, that is Amnurite P. We continue to launch innovative new products for the first time in India. For example, we launched Clobazam in 2.5 milligram strength. First time, add Clobaz 2.5, 5 and 10 in mouth dissolving tablet for febrile seizures, for pediatric epilepsy, for up titration and down titration. And very soon we'll be launching first time in India vitamins for a vitamin therapy for migraine. And with your support, we'll continue to launch innovative first time in India products. Now I have great pleasure in introducing Dr. Nilesh Poddar, our coordinator today. He is a young and dynamic endoscopic neurosurgeon from Mumbai. He is also a director neurosciences of Vedanta Hospital in Thane. And he also practices as a freelance neurosurgeon in Mumbai. Over to you, Dr. Nilesh Poddar.
I wish you a very warm good morning and a happy Akshay Tritiya and happy Ramadan to all of you. Today's webinar of international live webinar. We are doing the series of endoscopic spine surgery distensive technique. Today's topic is endoscopic lumbar canal decompression. We welcome our expert panelists one by one. Dr. Son, who was supposed to join us. He is from Korea, but due to some technical reason, he is not able to join with us. So we'll introduce Dr. S.N. Rohidas sir, a well-known endoscopic neurosurgeon from Kolhapur, and he had started the endoscopic spine surgery by distensive technique in India around 20 years back. Our second speaker, we welcome our second speaker, Dr. Mohinder Kaushal, a well-known spine and knee sports surgeon from Chandigarh, and he has a vast experience of 18 years in spine endoscopic surgery and expert in doing minimal invasive spine surgery. Our third speaker is Dr. P.C. Day, a director of orthopedic care hospital in Bhubaneswar and expert in minimal invasive spine surgeries, and he has an honorary secretary to WESS. And lastly, I'm going to introduce Dr. Mukul, a well-known orthopedic surgeon from Chandigarh, and he has also done the fellowship in UBA technique from South Korea, and he will talk on the UBA technique. So right now I'm giving this session to Dr. Rohidas sir, for he will give their expert views on endoscopic spine decompression.
Good morning. Good morning, everybody. I will start my lecture. I am sharing my screen now. Okay. Today we will talk about lumbar canal decompression. Now, when we talk about lumbar canal decompression, we have to start when we started with this endoscopic technique in 2002. The treatment of lumbar canal decompression is related to the developments in the optics and the added instruments what we use during the endoscopic spine surgery. We started with a simple disc in 2002. But as we tried to create a brand value, the next disease was the lumbar canal stenosis, with disc or without disc. And we had to offer endoscopic treatment to these patients. And this is how the treatment of endoscopic canal decompression developed with the distant use technique. I like to share this slide, how to choose your love. First is work on the subject which others have not worked on it, not explored. So that we started in 2002. Nobody has started with the endoscopic spine surgery. We started with that, with the single chip. But we focused on it. If we would not have focused on it, then we would have shifted to other modalities also. We waited for the developments in the optics and the future developments. We did it persistently. And what we tried is we tried that let the others know about it with our work. And that helped us. Those who have joined for the first time in the webinar, they were not in the last webinar. With just 2 or 3 slides about the distant use technique. I started this in 2002. Air-based endoscopy. This is just for the comparison. Everything is air-based, where we dilate the tissue and start working. Only system can be used for all the technologies as the future developments took. It is the cheapest system and it can be used with the 3D endoscope. This is how we use the 3D endoscope, which is just like a routine endoscope, 4 mm, 18 centimeter length. This is the distant use outer tube and inner tube, suction in the left hand, working instrument in the right hand, and it is mobile in all directions. This is the mobility of the system. This is just to introduce what we show the endoscopic picture. This is because of this system. The image is transmitted to the video screen, and looking at the screen, surgeon has to work. This is what we started in 2002. And when these cases of lumbar canal stenosis came to us, opting for the endoscopic treatment, then we would have to think of it. This single chip camera was with us till 2008, and we had to work with this single chip image. There was no depth appreciation. Now, this is the surgical anatomy of the canal stenosis. The medial facet hypertrophy is there, which is related to superior articular process and the inferior articular process. Superior articular process of the inferior articular process of the superior. And there is a hypertrophy of this, and it compromises the lateral races. Usually it is bilateral. So this is the traversing route. This is the hypertrophic medial facet, superior articular process of the inferior. It is compressing the traversing route at the area of the disc space and the vertebral body. So this is the lateral races. Still it is exciting through the foramen, and here it becomes the exciting route down caudally. So this is the traversing route compressed in the lateral recess, and when it goes out, it will become the exciting route below. So this anatomy we have to understand, and usually this is bilateral and age related. So we have to tackle and decompress the traversing route in the lateral recess. It was the wide laminectomy, which was the traditional approach. Young et al. Introduced concept of laminotomy.
बोलिए.
Unilateral approach for performing bilateral decompressive laminotomy, in which ipsilateral side of the canal is decompressed first, and then the contralateral canal and lateral recess is decompressed. Midline structures are kept intact. In 1993, surgical bilateral decompression laminectomy with unilateral approach with preservation of the paravertebral muscles attachment was reported by Jawson and McCormick. This is what we got in 2008, but before 2008, it was really difficult to identify the structures and have the depth appreciation. Then, this is the mobility of the endospine. You can go caudal, cranial, you can angulate it, you can rotate the Kerrison punch in any direction and access 360 degrees. This is how you can shift the whole tube, outer tube, inner tube, endoscope, instrument with the hand and access the cranial or caudal, medial or lateral. We can use this technique for multiple foraminotomies. These are multiple foraminotomies with decompression on the opposite side, and in between bone is kept intact so that this bone is useful for muscle reattachment. The muscle which we have separated out from the lamina and retracted laterally, it gets attached to this remaining part of the lamina which is not compressing the neural structures, and this helps in preserving the stability. We can use a Kerrison punch with angulation towards the opposite side. We can use a drill, and this is how we can angulate and go on the opposite side. This is the ipsilateral route and this is the contralateral route. Through the same incision, we are inside the spinal canal. Base of the spinous process is here. So as the patient started to come to us, we thought of using a drill. This is the endospine, 12-degree angle. System can be moved in all directions. Now this is a video of the opposite lateral races. This is the base of the spinous process. This is the lateral edge of the dura and the traversing root. And you can see we are using a 3 mm Kerrison punch to de-roof the lateral races on the opposite side. The cutting edge of the Kerrison punch is always away from the neural structures, so it is more safe. Most of the time we train to decompress the opposite side more than the ipsilateral side because of the very nice vision with the angle. This is the end result. This is ipsilateral root, shoulder, axilla, and root going down, and this is the contralateral root. You can retract both the roots medially, so you can judge the adequacy of the neural decompression and mobility. We started using drill. This is with the HD, but we started using drill with the single chip camera. This is opposite medial hypertrophied facet. You can appreciate this is the flavum here. We are using a cottonoid. This is flavum. So the dural tube is protected by cottonoid and the flavum. Now we are undercutting the opposite facet with the Kerrison punch. This is the drill we started using in 2006. This has a protection sheath. It can be moved up and down. So this protection tongue-like sheath will help us in protecting the dura. So there are three protecting things. One is the cottonoid underneath the ligamentum flavum, other is the flavum, and this is the metal sheath, which will protect the neural structures. And then you can angulate. This is the drill with the protection sheath. This is the medial facet. This was in the initial stages when we were using single chip camera to protect the neural structure. Everyone was skeptical, and we wanted that our complications should be as minimum as possible. We should be able to protect the neural structures. This is how we started using this drill with a protection sheath. Then as the things progressed, more critical cases with more severe stenosis, no interlaminar space at all, such cases started to come. And in 2006, we started using this technique for cervical approach also, where drill was mandatory. And in cervical, we were dealing with the cord and the vertebral artery. So we thought of having some instrument which will remove the bone. At the same time, it will not harm the neural structures. So this is the ultrasonic bone dissector. I started working on this in 2007-2008, and this was in market in 2010. It selectively removes the bone by ultrasonic waves. It doesn't damage the soft tissue. I started working with this Zuring company in 2008. Initially, I had asked the Sonapet people, but they thought that by increasing the length of the handpiece, the power will come down. But nowadays, Sonapet has also a longer handpiece. Then I contacted these Zuring people, and they thought it will be possible, and they made it. This is the ultrasonic rasp, and I am undercutting the medial facet. You are able to see this bone dust here. You can undercut it. I am undercutting the base of the spinous process and the opposite lamina. This is the flavum, and this is how we are undercutting. You can use a knife also. This is ultrasonic knife. This is a severely hypertrophied facet, and I am undercutting it so that the medial hypertrophied facet, which is compressing the opposite lateral recess, is removed. This is the flavum here. This is the hypertrophied facet. This is the flavum. So this is the flavum. Dural tube is here. We are on the opposite side, and this is the hypertrophied medial facet. In this video, you will be able to see we have decompressed the ipsilateral root here, and we are going on the opposite side. This is the base of the spinous process, and this is the flavum in the opposite lateral recess. I am retracting the dural tube with the suction. This is the opposite root. contralateral traversing route, and this is the flavum. This is the traversing route. Shoulder is here. This is ipsilateral route. This is contralateral route. I am retracting it. So you can access the opposite lateral route up to the foramen. Now this is the ipsilateral traversing route. This is the contralateral. So this is right and this is left. This is in the axilla. This is with the 3D endoscope I started using in 2016. This was with Vision Sense. This is the 2D image of a 3D. This is ipsilateral route and this is contralateral route. Ipsilateral and this is contralateral. Contralateral route I am retracting it. We can use this technique for 2 levels to decompress 2 levels with single incision. Okay, such like this. Ipsilateral route on the right side, caudal route, this is cranial, and this is on the opposite side. You are able to retract the opposite route medially. This is the lateral edge of the dura on the opposite side, traversing route, and you are able to see the annulus here. This is opposite annulus. This is opposite annulus. These are the 2 levels. This is L5S1 and this is L45. In between bone we have kept intact. This is the ultrasonic bone dissector to undercut the bone on the opposite side. You can appreciate both the levels. This is L45 and this is L5S1. In between lamina is kept intact for muscle reattachment. This is the dural closure. In case of a wide dural tear, we can use anasto clips. We can use fibrin glue with muscle. We can use tissue dura patch. So many options are available. This is one of the fear in the mind of the surgeon, how to tackle the dural puncture, dural tear or dural trauma. These are the cases. This is till 2016. I have divided into 3 lumbar categories. In lumbar spine where only discectomy was needed. Second was discectomy with canal decompression, and the third was those patients where I wanted to do only canal decompression. These were the complications. Dural puncture in 29 out of 1275 cases. I had to convert it to open, nerve injury in 4, recurrence 25. Now I have something around 50 recurrences in 1750 cases. Excellent results were in 96%, poor in 1. And this is the data about the listhesis cases. I did about grade 1 to 2 listhesis, total 55 cases, 1 dural puncture, and there was 1 inadequate neural decompression which needed fixation. The other surgeon did it. So this endoscopic canal decompression, it is less invasive, easier access to the opposite side from the same side by tilting the scope by 30 to 40 degrees, which is really difficult in obese patients with a fixed tubular retractor with the microscope. We can address the damaged areas that we cannot access by direct vision. We can confirm the compressed nerve root directly under the hypertrophied superior facet, which is not possible by direct vision. We can keep track of the anatomical position and perform the decompression position under vision. This method has advantage that we can use it for multiple levels. In few cases, I have taken these horizontal incisions like in UBE. These are the 3 levels which I had operated. This is a case, young farmer, canal stenosis, multiple level with a disc. So I did 3-4 discectomy and 4-5 L12 and D12L1 decompression. And this is the patient after 6 months. No fixation, mobility is preserved as normal. He can do his routine field work in farm. And these are the incisions. D12L1, L12, L34, L45. With preservation of the stability. This is the brochure about the courses which we conduct. This is the book. All the information is available in the book. I just show one. These are the cases which come to you. Yeah. This is the L4-5 canal stenosis. Disc is not that significant. Hypertrophied ligamentum flavum. You can see this is a severe stenosis. We are not able to see the dural tube, flavum hypertrophy, and the facet hypertrophy.
So your screen is not visible.
Not visible?
Voltaire slide is only being seen. The art of medicine is amusing the patient.
1 minute. Now?
Yes, sir, we can see a lot of images and...
Now? Single image?
I think it is loading. I can see your folder. There are a couple of MR pictures followed by your...
Let me... Now?
So I think you'll have to stop your screen share and then restart it again because we are able to just see your...
We'll go to the next presenter. We'll go to Mohinder and then at the end I'll share the case. Okay? I'll stop here now. Yeah.
महेंद्र अनम्यूट करो. Unmute, yes.
Good morning, friends. Again, back. Corona times. Webinar sitting in your bedrooms and drawing rooms. So I will be again carrying forward the thought process what Dr. Rohidas has set the ball rolling about lumbar canal decompression. endoscopic cystate.
रोहिदास म्यूट करो.
Why my slide is not moving? Yeah. So, friends, greetings from Chandigarh. As we know that lumbar canal stenosis is a disease of elderly, and the symptoms occur because of narrowing of the vertebral canal due to varying degrees of disc herniation, bulging discs, facet joint hypertrophy, cyst formation, ligamental hypertrophy with buckling. In some cases, there may be associated spondylolisthesis. As we all know, the symptoms are progressive neurogenic claudication, radicular pain, and weakness. And claudication pain occurs usually due to central canal stenosis and radiculopathy from lateral recess encroachment. So we have to understand the pathophysiology. There is a central canal stenosis and there is a lateral recess stenosis also. And these two issues need to be understood by surgeons when they are planning any kind of decompression. If the most common cause of inadequate decompression which we come across is due to inadequate recess decompression. So that's very, very important for us to understand. And the mechanical back pain which may occur is usually secondary to dynamic instability or spinal deformity. This is very important. Predominantly these patients come to us for leg symptoms or neurological claudication and least because of back pain. They have been living with a back pain over the years. It is the claudication which brought these patients to a doctor for reasonable solution. Having said that, the surgical decompression for symptomatic LSS is most common indication for spine surgery in patients older than 65 years, and it has been shown to improve pain, disability, and health-related quality of life. Laminectomy, as we all know, Dr. Rohidas has already enumerated the problems associated with laminectomy, so I'll not get into the details. The soft tissue problems, the bony problems are which are associated with laminectomy. We all know that, and it has been seen that incidence of post-laminectomy spondylolisthesis is about 5.5%, with 1.8% of patients requiring reoperation for instability. Patients with preoperative spondylolisthesis undergoing decompression alone are nearly 10 times more likely to undergo a subsequent additional stabilization procedure than their stenosis than parts who doesn't have a spondylolisthesis. This is very important here, where the great advantage of these minimally invasive endoscopic spine techniques they come in over open techniques. And when you're planning a fusion, I think this adds to the cost and also adds to the risks of the intervention or surgery. So surgical decompression is the most commonly recommended procedure, and with the advanced age, multi-level disease, associated comorbidities, and high morbidity of open spine surgery, they are the poor predictors of poor outcome. This is to be understood. So minimally invasive endoscopic cystic decompression in present scenario is an ideal option. So I think Dr. Rohidas has been doing since 2005 or 6. I also started, I think, almost the same time. Then Dr. Destendu, who has done thousands of cases. So we have now adequate scientific data to support that these procedures are the now gold standard procedure as far as Destendu technique is concerned. He is the first one to start these techniques. Most of new techniques are coming in, which are basically subscribing to same philosophy, but Destendu started. So as you all know, the system, and there is another orthospine system, which is my innovation, which also follows principles of Destendu endospine with little add-on features, which subsequently I'll share in my presentation. So just to share about this system, I started my endoscopic spine journey in 2002 after visiting Dr. Destendu. I think Dr. Rohidas visited about few months before me, before I went to Dr. Destendu. Then there were certain issues which I was feeling that I need to address. Then I went into design a first generation arthrospine system. In 2004, I was granted a IUA, Indian Orthopedic Association research grant. So I did this project under that. And then there were some problems. I mean, this is what innovation is. You come across certain issues, you again innovate, invent, and something add-on happens, which again improves or adds to the patient care. So now, last year we again innovated our existing arthrospine system, and we designed a second generation arthrospine system, which has certain advantages. This is such a simple instrumentation. Arthrospine, most of the instrumentation is same as that of Destendu and the spine, but here we are using certain dilators, about 10 millimeter diameter max, and certain add-on instruments are there. Something like you can see RF probe and Buzz and Shavers have also come in the scene now with the further advances in endoscopic spine surgery. And this is again endoscopic MIS instrumentation system where surgeon is planning a cage grafting followed by percutaneous MIS. This all I have been working with JESCO, which is a FDA approved Indian implant company. So with their support, we have been able to devise this instrumentation. And same here, you have a 30-degree scope with a single high flow sheath. If you see, sheath is there with a single inflow cannula, and it is high flow. The fluid comes from the front, and it causes hydrostatic pressure at the surgical site, and also controls bleeding to some extent. There are two set of dilators, 5 millimeter and 10 millimeter, and there is a tube. So you barely used to go to give a 10 millimeter incision. Then we have two working inserts. One is with the dry endoscopy, the same way the way we do Destendu technique, and another is with the saline. Once you are close to the dura or nerve root, and you want to move around the dura, the nerve root, then surgeon switches over to saline endoscopy, because one of the drawbacks which I came across with the Destendu system or my previous first generation system in air endoscopy, moment you are close to the dura, then there is a staining of the tip of the scope, and there I found if you switch over to saline, you can virtually get into the foramen. And this scope, if you see on my left side picture, this scope can be advanced inside, outside. It can be rotated 360 degrees. So whichever area you want, and once the fluid is on, you can virtually advance this scope into the foramina of ipsilateral or contralateral side. So this is again a feature of UV which comes in here. Virtually this arthroscope, which is a 4 millimeter scope with a 6 millimeter sheath, it can go into the foramina, and you can virtually peep into the foramina, and these are the additional instruments. These are BUR, RF, which are needed for saline endoscopy. So with saline endoscopy coming in, the cost of it adds to the surgical cost of the procedure, and these gadgets also are very, very costly. So from air endoscopy to saline endoscopy and then to UV. I am not very big fan of UV. I did visit Dr. Sohn, but I find the application of UV in my practices where I am planning a endoscopic MIS fusion, where this additional port for the scope is a viewing port, and here where I am using a RF, I use a cage and put in a bone graft from this. In routine, my discectomy and canal decompression, I only use arthrospine dual system or at times Destendu system, which serves in 90% of my cases, serves the purpose. So again, the advantage is why I have to work on existing systems to design an arthrospine dual system. Dry and saline endoscopy surgeon can use it, and once close to surgical target, to avoid staining of the lens, surgeon can switch over to saline endoscopy. Triangulation is, of course, is a matter of practice, and surgeon must learn to triangulate before he starts using these methods as treatment methods. And you can use in a UV mode also, as I shared with you. Just create an additional port and you start working in a UV port. Versatile design. You can use 0 degree or 30 degree scope, whatever in inventory you have. As I stated earlier, scope can be zoomed in or out to see inside the disc, can be rotated 360 degrees to visualize recess and hidden areas. And it is an indigenous design, so very, very cost effective as compared to our other new systems which are coming in the market. And the applications or indications remain the same as Descendio system. So that's what I want to say. But other extended indications with this system is endoscopic assisted MIS fusion, decompression in listhesis, and you can use put in a graft and cage under endoscopic vision. I have tried few cases of thoracoscopy also, and other pathologies also, intradural pathology, as our neurosurgical colleagues are routinely doing with this kind of system and Descendio endospine system. So again, mobility, I need not pay more stress because Dr. Rohit Das has already shared about the mobility of these systems. Mobility is a great advantage where you can work cephalate, caudal, medially, laterally, and one level above or one level below. So indications remain same as open spine surgery. That is very, very. So these are the systems where you don't have any limitations. It's not that you learn transharmonic also, you learn these systems also. I think this is one system, is solution to many of the problems which we face in degenerative spine. It's very, very important for surgeons to understand that this is a one interlaminar system, Descendio, or for that matter, arthrospine, where you can address your almost, I'll say, 100% of the problems. So these are again an operative technique to share with you. And again, the endoscopic view. And this is what is an adequate decompression we can call good midline decompression and bilateral recess decompression, as Dr. Rohit Das has beautifully demonstrated in his video clips, that what is the end point of a endoscopic spinal decompression. When the surgeon has done a good midline decompression, he has probed and mobilized nerve roots of ipsilateral side and contralateral side. I think that is the end point of a adequate endoscopic decompression. I mean, keeping a small skin incision doesn't mean that you are minimally invasive inside. You have to do a maximal invasive work inside, at the same time preserving the stability of the spine or posterior tension band structures of the spine. And again, incisions, I think we talk too much about incisions nowadays, 6 millimeter, 8 millimeter incision. I think the key is, it is not the incision which is important. I think it is the muscle damage which you have prevented while doing a surgical or a endoscopic procedure. So that is very, very important. If you have minimized muscle and bone damage, so as per me, that is what is minimal invasive surgery. It is not a small skin incision that is a minimal invasive surgery. That is to be understood. Post-operative protocols in these patients is morning, if you operate these patients, you mobilize these patients in the evening, and they can have a shower, and they are taught back exercise program also, and they can join their desk job within a week, and sports activities maybe after about 6 to 8 weeks. And my journey of spine endoscopy began in 2002. I've done close to 3,000 cases, but I have moved beyond discectomies and canal decompressions in lumbar, thoracic, and cervical areas. I have used this modality to do spinal flexure fixation. When I say that, I mean I try to push in the bony pieces which are protruded into the canal under endoscopic guidance, and I do a percutaneous stabilization of the fractures of the spine. It is a great tool to do endoscopic biopsy, and I have drained few epidural abscesses and also done decompressions, and of course instrumentation is always done percutaneous. With there you don't use endoscope, and I have been successfully doing now endoscopic MIS fusions from last almost about 5 to 6 years, although very small series. And the complications which I encountered in my series, as you can see, superficial infection, dural injuries 5%, and Dr. Rohit Das has beautifully shown a video how to tackle a dural injury, because dural injuries for a neurosurgeon, it is like opening a skin. But I have seen many of orthopedic colleagues who doesn't have a exposure to spine, for them it becomes a very, very scary situation. So there are very simple ways to address dural injuries, and I think one should know how to handle a dural injury if one is starting a endoscopic or a spine surgery practice. And nerve root injuries, really you can't do much about nerve root injuries, but still we can only pray that if it is a partial nerve root injury, then some recovery is expected. In a complete nerve root injury, at times some disability patients are left with some kind of a residual disability. So this is some of the literature which is published. Those who are interested can go to visit these sites and know more about the techniques. I have published the Stendu technique way back in 2012, and then another paper in 2016 on arthrospine system, and another paper is under publication. This is original article. Let's see which paper, which journal accepts it, then I'll share with you the further details. And I think just to share the few videos about my arthrospine dual and slide technique, I think these videos are with Mukul. I'll request him if he can slide share these videos from his place so that we can see how the saline endoscopy aids vis-a-vis dry endoscopy when you are close to a surgical field. Mukul, can you play those video clips?
Yes. You'll have to stop your screen share, I think.
I stop I'll come back again. Or what I do is I finish my presentation, then we see the video. Is that okay, Dr. Rohidas?
Yes.
So my presentation is about to be finished,
Yes,
then let
yes.
him play. So again, message to my younger colleagues, how to learn these techniques. I think the journey is uphill, but it is not impossible. So first visit your senior colleague who is routinely doing these kind of procedures. Stand with him in the theater, observe him, see how he manages the complications, then attend cadaveric workshops. Try hands-on models in your setup. You must have spine models and try practicing with the endoscope and your instrumentation on the models. I mean, then you go for a live surgery on your patients. You must practice and practice on models. Then only you get that confidence of how to move the tube, how to hold the tube, how to use the Harrison punch. I think the main problem which I have seen with younger colleagues is they straightway jump and start doing live surgeries. If they get a set today, they think tomorrow they will be able to do the procedure. I think that is a very, very wrong notion, wrong thinking. That is not the way to learn these spinal endoscopic techniques. So, as I stated, visit a surgeon, try hands-on cadavers, and then try to do first surgery in your theater. As I stated earlier, it is not the incision which is important. If you have respected the muscles and the bones which contribute to the stability of the spine, I think you have served the patient in a very correct and a successful manner. So I don't agree to philosophy that I do a procedure through a 7mm incision, 8mm incision. I think skin incision is more of a marketing gimmick than it is true essence of a philosophy of a minimal invasive spine surgery. So this slide also Dr. Rohidas has seen as far as principles are concerned, how you go over the top and do a contralateral decompression. So as I stated, adequate decompression. And I think interlaminar endoscopic surgeries for LSS are safe and effective alternative to open microscopic surgeries. They can achieve the same clinical results with added benefits of MIS surgeries. Spinal motion and stability is not compromised, hence fusion and implants can be avoided. Learning can be made easier by attending short-term hands-on cadaver and spine model trainings. And great improvements have been achieved in developing better techniques and tools in treatment of spinal disorders by minimal access endoscopic route in last decade, thus making spine surgery safe, effective, and less morbid. Thank you very much. Over to Dr. Mukul to show you the video clips. I will keep my audio on.
Okay. I'm playing the videos
You
now.
are playing now canal decompression?
Canal decompression in a dry mode through arthrospine.
Okay.
This is lamina identification, clearing the soft tissues of the interlaminar window in a dry mode. The initial bite at the spinolaminar junction. Below we can appreciate the ligamentum flavum. Exposure of the ligamentum flavum, detaching the ligamentum flavum proximally, putting in a patty, the cleavage plane between the nervous tissue and the underlying ligamentum flavum. Then performing a partial flavectomy on our ipsilateral side. Below we can appreciate the dura. Putting the patty on the opposite side so that we go over to the opposite side. And taking flavum bites on the opposite side. After doing the opposite side decompression, we can appreciate the opposite side root and the disc. That's the disc in front of the probe. And sometimes we face this problem of soiling when we are performing a dry mode endoscopy. So probably that's why Dr. Kaushal shifted over to the wet concept also. So here's how the wet picture looks like. This is the appearance in a wet mode. On the 9 o'clock, there is the lamina. In the center, the yellowish tissue is the ligamentum flavum. This is the junction between the flavum and the... Oh, sorry about that. Then starting the bony work with a burr on the spinolaminar junction. Superficial ligamentum flavum removal. Then removing the deep layer of the ligamentum flavum. We can see the dural tube down below. Generally, it is better to lift and bite the flavum, keeping the dura always in vision. And another thing is that when you're using saline, the saline tends to create a epidural pressure and pushes the dural tube away from you, as we can see here. Then opposite side working on the top, removing the ligamentum flavum. And then once done with the opposite side, you can appreciate the opposite side root also. The disc. This is the same side root being probed, disc below. And that's the final picture in a saline mode. I'll stop my screen share now.
Mukul, if you can continue that ear talk.
Okay, sir.
Yeah.
So I'll start my screen share.
Yes. By this time, can I ask a question to Dr. Mohinder? Mohinder, please unmute. Okay, you can continue. Mukul, you can continue. You are ready now. You can continue.
Okay, sir. So I'll be talking about this technique, which is a bit different from the conventional endospine and the arthrospine technique. It's a UBE technique, which is popularized in Korea by Master Sang Kyu Son. I think this is the new player here in the degenerative spine market. So to understand what is UBE, UBE is unilateral biportal endoscopy. And like all other procedures, it is also minimally invasive. It is basically a two-portal system in which you use one incision to introduce your endoscope and the other port to use your instruments. So this concept is almost similar to arthroscopy, and my bias is because I have been trained in arthroscopy. So I have a more bias and inclination towards UBE. The surgical approach, the anatomy, and the indications remain as same conventional open surgery or microsurgery. The basic concepts of orientation, triangulation as conventional arthroscopy are to be followed, and certain aspects like understanding the concept of multifidus triangle and Son space is to be understood to master UBE. Well, in a lumbar canal stenosis, generally the MR picture looks like this. Clinically, the patient is not able to walk. He gets claudication, buttock leg discomfort, and we aim to relieve that neural compression and aim for a post-op picture like this so that our patients get neurologically and clinically better. So this UBE is basically a fluid-based technique. Here, the scope sheath is introduced from one portal. The saline input is connected to that. The saline comes in through the scope sheath, and it creates a hydrostatic pressure at the operative field, and simultaneously that fluid comes out. Now, maintaining this patency of this continuous fluid output is very important to avoid and increase your chances of fluid complications. So generally, the epidural venous pressure and bone oozing are generally below 30 millimeters of mercury, and we aim to keep this epidural fluid pressure over 30 millimeters to minimize our bony bleed and create a clear operating field. And the output is basically maintained by the use of a UBE retractor, which acts as a valve to allow the fluid egress and also acts as a guide for our instruments to reach the site of pathology. Well, the armamentarium is a bit different. It is an endoscopic system, so you need a camera, light source. Well, you can use a 0-degree scope, you can use a 30-degree endoscope, you need a burr system with sheath, you need a radio frequency probe like in sports medicine we use, you need an irrigation system, you need a UBE nerve root retractor, you need a couple of angled pen fields so that they increase your reach, you need your standard Kerrisons, your pituitaries and general spine instruments. Well, the operating room setting is usually the operating surgeon stands on the left side, the assistant stands on the opposite side. His job is to hold the UBE retractor and to control the water flow. The scrub nurse stands on the same side as the surgeon. The monitor faces the surgeon, and the C-arm is generally required, usually in an AP as well as in a lateral view. The patient is generally placed prone on bolsters and with maintaining a neutral lordosis. Well, deciding there is a bit of conundrum on where to stand, because most of us surgeons are basically right-handed. So a right-handed surgeon usually prefers to hold the instrument. It gives him more control over that instrument when it's holding in his right hand, and hence standing on the left side and working on left side pathology is relatively quite easy. So whenever the surgeon is standing on the left side, his scope is in the left hand and it is coming in from the cranial portal. The instrument is in the right hand and it is coming from the caudal portal. And whenever you're introducing a burr, the burr tip, generally it is advisable to use it with a guard to avoid any deflection of the burr and causing an inadvertent neural injury. So the burr tip is easily seen when you're performing on the left side. But the problem is, as the scope tip and the burr are facing towards each other and your instruments are very close to each other, there is a risk of scope tip damage if the burr deflects towards your camera. While standing on the right side and operating in a UBE, the position of the portals change. Now your scope is entering in your left hand and it is coming in from the caudal portal, and the instruments are coming in from the cranial portal. And here the problem is, if we try to use a burr guard with a guard tip, generally that guard is going to hamper our visualization of the burr tip, and we will not be able to see the tip working when we are performing the initial laminotomy. So probably here using a burr without guard will help us see the burr tip, but using it without a guard increases your chances of either causing a neural injury or injuring our instruments. So deciding upon the skin point, in generally a central or a paracentral pathology or a central stenosis pathology, the skin point is basically, I would direct your attention towards the AP image, because most of the UBE procedures are localized on an AP image. So it is very important to orient yourself and draw a line on the skin, on the medial margin of the pedicle, on the midline spinous process. And proper AP is when the spinous process is in the midline, the pedicles are equidistant from each other, and the target level disc, the end plates are parallel to each other. On a lateral view, basically you want your disc level to be localized at the upper part of the disc, and your incisions are basically on the skin at the medial margin of the pedicle, but they are directed towards the upper edge of the spinolaminar junction. Now, understanding the concept of the multifidus triangle, if we look at the multifidus muscle, it generally attaches at the tip of the spinous process and then goes laterally to attach on the superior articular processes of the lower vertebra. So in essence, it is creating like a triangle. So probably to reduce approach-related morbidity, the surgeons, UB surgeons, try to exploit this white interfacial plane to introduce their instruments and their scope. So this is the multifidus triangle concept. Then there is a potential space which was basically named by Dr. Son. This is the Son space. So when we look at the axial image, there is a little fibrofatty plane between the bone and your muscular tissues. So this plane is generally exploited in UBE. So whenever your scope and your instruments lands here, you turn on the fluid. So you try to enlarge this fibrofatty space through the input of your saline. And once this space is enlarged, it gives you an initial working space. Then you use your radio frequency to clear the lamina, the interlaminar window, and then burr the spinous process and the spinolaminar junction to get a true working space in UBE. So the decompression steps, I'm trying to picturize it. Initially, it is very important to use an image. Mostly the UBE is done in an AP view. So always mark your midline, mark your medial pedicular line, mark the target disc level, and these are your, generally the distance between the two incisions is about 3 centimeters. So keeping the center of the target level as your center, about 15 millimeters proximal and 15 millimeters distally, the skin incision is given on the medial pedicular line. Generally, the UB surgeons prefer a transverse incision. Skin incision is transverse, then with a number 15 blade under image guidance, you give a facial incision with your skin with your 15 number knife directed towards the spinolaminar junction. Don't try to go below the fascia, otherwise just nick the fascia and just come out. Then you put in your serial dilators. This is from the caudal portal landing at the spinolaminar junction, and then using a then you do serial dilatation with a 5 millimeters, 7 millimeters, 9 millimeters dilator, and then use a detacher to detach the soft tissues from the spinolaminar junction. And similarly, you use the cranial portal to put in a scope, and both of these should be checked under image also, that they are both colliding with each other, and with the feel of the instruments, you can also feel that they are touching the bone and touching each other. This is how the outside picture looks like, and this is how the setup looks once you start the UBE. So this is basically a UBE retractor. It is just like a nerve root retractor, and it is very important. This is to be held by the assistant. So it has a multitude of functions. The saline input which is coming in from the scope, this thing creates a channel so that there is a continuous egress of the fluid exit. It also helps to retract your fascicles of the multifidus and the soft tissues, and most importantly, it acts as a guide for your instrument passage. So the steps of decompression are, generally once you land, put in your scope, you radio frequency the soft tissues to get a clear vision of the lamina and the interlaminar window. Usually bleeders are there at 4 o'clock, 8 o'clock. We start our burring at the base of the spinous process. We go proximally, performing a laminotomy, and then same side we burr till the ligamentum flavum detaches. Then we identify the midline cleft in the ligamentum flavum, do the sublaminar burring on the contralateral side to create a space to detach the ligamentum flavum on the opposite side. And then we detach the same and the opposite side ligamentum flavum with angled pen reels. We remove the superficial layer of the flavum all around, But one has to be very careful while working around the recess area. That is the SAP lamina junction of the lower vertebra, where your traversing route generally emerges from the dural tube. Preserve the deep layer. It acts as your shield against the neural tissue, till all your bony work is done. Always use your pen fields and blunt probe to separate any regions between the deep layer of the dura and the flavum before taking the bite of the deep layer. And finally, we reset all of the deep ligamentum flavum to complete our decompression. So this is a little small video of this UBE technique. We can appreciate the lamina and the interlaminar window towards the 3 o'clock. Then burring is done at the base of the spinous process, going proximally, detaching the ligamentum flavum. Underlying, we can appreciate the epidural fat and the dural tube. And once it is all done, it looks like this. This is the ipsilateral side disc with the traversing route, and the epidural fat is maintained in between, and this is the contralateral side. So basically, this is how it looks like. The outside view is somewhat like this. Scope entering in from the, this is a left-sided approach, scope entering from the cranial portal, instrument going in from the right-sided portal. Inside, it looks like this. This is the UB image. That's a UB retractor retracting the dural tube. This is the same side disc. On the right-hand side of the pen field is the traversing route. And the contralateral disc can also be approached by this UB technique. We are using the UB retractor from the same side, going over the top, placing it on the opposite side. That's the traversing route. The disc can be appreciated. It's a stable contained disc. That's the contralateral side approach from similar side. So complications are just like any conventional open surgery. One can end up with epidural hematoma. We can cause a dural tear. Infection is reported. Undercutting and working around the facets may lead to formation of a synovial cyst. There can be recurrence of disc or a stenosis. But certain complications which are unique to the UBE procedure is, as we are using a radiofrequency probe, we might cause some thermal injury to the neural tissue, which can be ideally caused by a direct contact of the probe with the neural tissue, or as this radiofrequency, it creates a plasma in front of its tip. That plasma creates a local area of high temperature, which can cause a low temperature burn indirectly, even if the neural tissue doesn't come in contact with the RF probe. And there has been instances of massive fluid collection while utilizing this UV technique for extraforaminal and foraminal stenosis through a far lateral approach. And probably as you are working, as your instrument and your camera are in separate hands and independent of each other. So orientation, one getting disoriented, one not able to triangulate is a real issue here. Bleeding control is a problem, and there is a risk of damaging your scope as your instruments are very near to each other. Well, the differences between this the uniportal PELD techniques and the microscopes are that most of those systems are using one or other kind of tube, and this UBE is basically a non-tubular system. And as one is working through a tube, the tube, it restricts your mobility, whereas there is no mobility restriction in a UBE. Probably if you are a transforaminal surgeon, you have to understand new surgical anatomy, understand the concept of the Campion triangle, but in a UBE, an arthrospine or a distendo system, it is a classical posterior interlaminar surgical anatomy which everybody is well versed in. And the indications of UBE are same as for any other condition requiring arthrospine, endospine, or any conventional open posterior surgical approach. But the edge which I feel is that in UBE, with your eye, it can't get any closer than what it is possible in a UBE. As your eye, the camera, and your instruments, they move separately, so you get more mobility. The over-the-top contralateral route and foraminal decompression is probably under better visual control. And in fusion surgeries, it is better, allows us to prepare a graft bed under better closer vision. Sorry about that. But the flip side is also there. Learning UV, you need to invest in additional instruments like radio frequency, which are expensive. The bond is not, it is not reusable, can be reused, but it gives way after a couple of cases. But triangulation, when you're working through a tube, the advantage while working in a tube is that the camera and your instruments are going to come in front of each other. So learning triangulation is not that tough. But when your instrument and camera are independent, then probably triangulation is even more tough to learn. And as you are working very close, the orientation loss can be quite significant. There is a risk of damaging your scope and wearing out your instruments as you are working very close. You need an assistant for a UV retractor, whereas in the endospine techniques and in the arthrospine techniques, you don't need any assistant. The surgeon is fully in control. And there can be fluid-related issues that if you increase the epidural pressure, the patient may start complaining of shedding. He might develop epidural hematomas. He might develop seizures or signs of meningism. As a beginner, I think if one wants to pursue this UV, they can join this UV group on social media, ask questions to the masters there, visit the master himself, orient and triangulate on bone models, attend cadaveric courses. Initially, only stick to left-sided cases. Avoid very tight stenosis in your early learning curve. Initially, the UV masters, they utilize a transverse incision, but I stick to a longitudinal incision because if I get stuck, it is easy to convert to an open or a microscopic technique. Always perform multiple checks with the C-arm. There is an issue of bleeding. It can be controlled by having good rapport with the anesthetist, control the BP, ensure that you're standing there in the OT when the patient is positioned, check that the abdomen is free. Probably tranexamic acid might have a role as it is coming. There are few papers coming out in shoulder arthroscopy that it helps in improving visualization. Judicious use of your radiofrequency probe, Surgicel, bone wax, patties, gel foam, and finally FlowSeal. But if a dural tear occurs, it is better to abandon the procedure and convert to open in your initial days. So all of these techniques I've learned from the master, and I would suggest that you guys, if you're interested, you should visit Dr. Sang-Kyu Song to master UVE. Thank you.
Nice presentation, Mukul. Now my turn. The slide is visible? Rohidas?
Yeah.
It is visible.
Visible, sir, visible.
Okay. So come back to again this after the MK system and then UBE, we are now coming back to again that endospine system, the DESTENDO system. My preferred method is endoscopic spine surgery for the disc herniation and lumbar canal stenosis because these are the things I just like to highlight. This is the pathology already we have discussed, that we are doing the central canal and lateral canal at the same time if necessary, or only central canal as per the need of the patient. And the technique that we are just angulating the instrument, going to the opposite side, undercutting the bone without cutting the whole set of the bone, just undercutting the spinous process and then the lamina and the hypertrophic part of the facet up to the foramen and decompressing. So that's why it's called a functional spine surgery by DESTENDO technique. Unilateral approach, bilateral decompression, remove the lesion without disturbing the anatomy and stability, so preserving the motion and function. All are contraindications, not contraindication, that means all are indication. Like the one thing I just highlight here, that the spondylolisthesis even grade 1. Now I think everybody is full endoscopic technique, transforaminal technique, UV technique. Everybody is now proposing that in spinal listhesis in grade 1, you can have the decompression without fixation. So this is the way we are avoiding the fixation, even sometimes 3 level, 4 level like this. We are doing the laminotomy, trimming the bone, removal of the hypertrophic part of the facet, and excision of the ligamentum flavum, which is hypertrophic part, and associated disc. If there is a disc herniation, you have to. So this is a case of L4, L5 disc with the lumbar canal stenosis. disc with stenosis L4, L5. So this is my NORB root retractor to protect. This is the left approach, and the left side is this. The 3 o'clock position is the cranial, and this is the caudal, midline, and lateral. So left side is your cranial, and this is a left approach. This is the disc removal from the same side, and then this is the hypertrophic part of the ligamentum flavum, along with a chunk of hypertrophic bone of the opposite side. That this is the spinous process at the midline, and just undercutting little bit of the spinous process and the lamina of the opposite side. This is the NORB root of the opposite side. That is the right side NORB root. This is the right side NORB root of the opposite side. And if you want, you can have the disc from the opposite side also, if you want to remove the disc, but it's very, very rare that you have to remove the disc from the both side. Very, very rare. So this is the discectomy from the opposite side, but it is almost not necessary, 99.9% cases. So this is the NORB root of the same side, is decompressed up to the foramen, right? So this is the another case, 56 years male patient having the left more than right pain, complaint of the pain, lower limb pain like about 12 months, but this aggravated for last 3 months. There is involvement of the bladder, and also there is a cauda equina syndrome. Patient not able to walk even for 2 minutes at a stretch, severe pain. He has some bony abnormality, congenital bony abnormality, but now at present the L4, L5 disc herniation and also the stenosis. So this is the another peculiar case at L4, L5 disc herniation and the stenosis. Patient complains of the pain and also the blood involvement. The disc at the right side, as I told this, the complaint is more on the left side, and the pain is continuing at radiculopathy in the left side, but the disc is, I think this is a calcified disc and sitting on the right side of the NORB root. So this is the short video I'm just going to show you. This is again, this is a left approach because the patient complaint was on the left side. Left approach decompressed the dura, and now the opposite side. And this is the calcified part of the extruded and migrated little bit downward, calcified disc. And we are removing the disc from the opposite side. It's a big mass, calcified. We have removed in a single piece. So decompressed from the left side, discectomy from the left side, and remove the disc, extruded and migrated little bit downward. And that was the calcified part, decompress the NORB root of the both sides. And this is the beauty of the technique. You can angulate, you can go to the opposite side, visualize the opposite side, and adequate surgery of both sides can be done under the vision. This is the beauty of the technique. And very rarely, this is the so this is the we are just irrigation of the. There is echo. Somebody has to mute, I think. Okay. So the same patient with cauda equina syndrome who was not able to stand, or even next day morning he is able to walk few steps in the corridor of the hospital, though little bit limping is still there. Contralateral visualization of the lateral recess and the foramen are vastly superior. During the contralateral decompression, the Kerrison punch angle, that angle of the Kerrison punch pushes the dura and the NORB root, so protect. Therefore, the contralateral decompression of the lateral recess foramen can be performed safely, more thoroughly, and endoscopy. I just wanted to say here, Dr. Vidas mentioned and highlighted the two things, that is drill and the ultrasonic dissector, that bone dissector. He is using for last 10 years, more than that, very safely, and it is very good. And also Dr. Mohindo informed that there are two things he is using, that RF and then the Saver bar, that is also used by the UBE technique by Dr. Sun. So same thing, I think both the four instruments, the drill or ultrasonic bone dissector, and then RF to coagulate and decauterize, and also the Saver bar, that is the very good. All four are very good instrument. The saver bar and the drill, both are having the protective sheath. So you can protect the neural tissue, dura, everything, then go ahead. So this is another case, is 69 years retired state government doctor, CDMO, having the bilateral foot drop, severe pain, burning sensation, and there is a coda equina type of symptoms. He was suffering like anything, and then he got the first surgery at fixation at L4, L5 level, and the second fixation at the L3, L4, and then both merged. So twice operated. And when he came to me, presented with the severe pain around the perineum, and he was not able to tolerate for last 2 years after the surgery. I saw the discharge summary, wrote clearly there is bilateral nerve root injury and the CSF leak, dural tear, everything. So he was almost not able to stand, walk, and with support, little bit, maybe hardly 1 or 2 steps. He was begging for the surgery, and I was avoiding him because already twice operated, bilateral nerve root injury, CSF leak. With the help of my neurology colleague, I tried to help him for the treatment, but it is not convincing. So again, he was blackmailing me almost for the surgery, and I was avoiding anyway. He got admitted in the hospital without my permission. This was the L1, L2, and L2, L3. There are 2 levels above and 1 level below, that is L5 base 1. The 3 level stenosis, severe stenosis, 2 level above and 1 level below the fixation. Keeping the fixation in situ without disturbing that, with the help of the endoscopic technique, we dare to approach that technique, and then all the 3 level I did, and in 2016, now for 4 years past, he is very happy. Even after that, 1 year after, I have operated his wife also, that is 3 level stenosis again by endoscopic technique. So that the next day morning, the patient was very happy. The total gone of the burning sensation. He was able to walk up to the toilet, and that was the photo of next day morning in his hospital bed. Another patient is 92 years patient having the severe stenosis L3, L4, 15 days history of the pain and the bilateral foot drop, bilateral weakness of the lower limb, and bladder bowel movement. Catheterized, shifted to the patient to the hospital, admitted, done all the investigation, MRI, cardiology checkup, everything. But I think they have not advised for the surgery. They discharged the patient. In the same day, they shifted to the patient to my hospital in the 10 o'clock in the night. And next day morning, I took over the surgery, did the surgery at 10 o'clock morning. And next day morning, patient was able to stand with the support. And in the 3 days, we have removed the catheter, and patient is walking and coming to me with the help of a stick. And he is very good and happy. Now I'm going to my next talk. I have to, I think, stop this here, then again. There is some problem, I don't know. Yes. So this is the patient. Mukul, it is visible? Is okay?
Yes, sir. It is
Okay,
visible,
sir.
sir.
Okay. Okay, so this is a patient of 38 years, 2 years pain, gradual onset of pain, radiculopathy, and weakness, tingling, numbness. There is no history of trauma and no other congenital anomaly. He is only 38 years, and this is the situation. There is L4, L5, little bit seems to be, I don't know what is the status at L4, L5, but it seems to be a little bit started, but I think it is normal for me. there is a severe stenosis at L4, L5, almost the grade 3 or grade 4 as per the CJAS classification A, B, C, D. I think it is C or D. There's a huge stenosis and disc at L4, L5. There is a disc associated with the, I think you can see here, the L4, L5 almost blood, nothing is visible, both the dural sac and the nerve root bilateral. So this is the way he presented me. This is the, I took the surgery. I just wanted to ask Dr. Rohidas, can you unmute Dr. Rohidas? This is a, as for me, it is a congenital anomaly of the stenosis. Can you unmute Rohidas? So just tell me what is the other investigation I need to do it here in this stage to know any other problem or expecting something different pathology here, because I think it seems to me it is a congenital anomaly at 38 years, severe stenosis, maybe CJAS 3 or 4 of like this, and bilateral, and patient is having severe pain for last 2 years. Rohidas.
I usually don't do any further investigations.
This is enough. X-ray and MRI and everything is enough. Clinical examination, patient is walking and there is no neurological deficit, but severe pain, bilateral radiculopathy. I think the grade 4, 5 like this, the power. And there is EHL also, I think the grade 4 or 5. Mahinder, can you unmute? Can you comment on this? Unmute. Mahinder, unmute.
First, you have not told us symptoms of a patient. Then the clinical examination, you have shown us beautiful MRI, you have shown us X-rays. There is a grade 1 sort of listhesis. So I will like to know more about the history and complaints of a patient.
Yeah, history I told that is bilateral lower limb pain, radiculopathy for 2 years, gradually increasing, is a gradual onset. And also this is a bilateral involvement, and I think almost same of the bilateral, but the pain aggravated for the 10 to 12 days, severe pain, but there is no neurological deficit.
And what about his walking distance, neurological claudication?
Is less than 200 meters.
And about his back complaints, back pain?
Back pain, intermittent, not regular.
Okay. So now, since after seeing the X-rays, I will like to take his dynamic X-rays.
Yeah, dynamic X-ray we have taken already. I think we have not shown here. Dynamic taken. It is not
and then I will, after seeing MRI which you have shown, I will sit down with the patient, do a very good counseling. I'll share with him the problem in the back, which may not be giving him back pain now. Number one, I'll tell him that maybe with endoscopic canal decompression, with or without discectomy, you will be happy. But in case you, after 6 months, tell me that my back is not troubling, my leg symptoms are not there, then probably I will tell him you have to take a call on endoscopic MIS fusion. That is a standby procedure just to educate the patient. Otherwise, these patients, I have seen few patients, I have done a very good decompression. They are very happy as far as leg symptoms are concerned, but they keep coming to you and keep telling you about also back pain ka kuch karo, back pain ka kuch karo. So if you have counseled them in the first stage, probably they will not come and trouble you again and again, and they will understand that endoscopy was only done for neurological problem, neurological claudication, not for back pain. And if they are having a disturbing back pain, I think there is a solution, because in 90% of cases, back pain is really not the issue. It is the 5 to 10% of patient which really come back to you, and that surely contributes to a fair or a poor result of our outcome.
Yes, it's true, because of this lumbar canal stenosis, mostly the degenerative, and starts at the age of 60 or more than that. The usual symptom is the 95% back pain and 91%, I think, the radiculopathy. 72 to 73% there is a weakness, and I think 12 to 15% there is a bladder involvement. But here this boy is very young, and it is having no back pain, intermittent back pain sometime, and not hurting him, but radiculopathy bilateral. And do you think any conservative treatment like injection therapy or will work here?
No. I am against giving injections in this very patient. I don't think that is just cheating a patient.
Okay, straight away then we will go for the surgery here.
Yeah. Even if this patient comes to me, please give me an injection. I don't want endoscopy at this moment. I'll tell him go elsewhere for injection. There are many guys sitting in the market who are just waiting for such patients to give them a shot in the back. But I will not surely advocate injection in this very patient.
Any precautions in this patient, because the patient is not is a young man and very stout bone, no degenerative bone, there is no osteoporosis, no weakness, and also in endoscopic technique, do you think any precautions you should take it here?
You see, first thing is ki there is a grade 1 spondylolisthesis, that is a sign of instability. So instability can happen at the age of 40 years because there are stages of spinal degeneration. There is a stage of instability, then stability, stage of dysfunction, instability and stability. So he is probably going through a stage of dysfunction. He surely has a unstable spine, and if you do CTs, maybe you will find some changes in the facets also. Now you are asking ki what precautions you will like to take during surgery.
Correct.
I think in routine, standard manner, but surely you should be mentally prepared. If facets may not be normal here as in standard normal case where there is no kind of a slip. And I am sure there will be a thick ligament of flavum also because at young age there is a unstable spine. So because of abnormal mobility, these changes have occurred.
Okay, let us see the surgery. It's hardly a small video. This is a first bite at the spinal laminar junction. This is a left approach. And left side of ears is the cranial. This is the cranial and this is the caudal. This is the midline and lateral. So patient, I am approaching from the left side. My left hand is the suction tip. Right hand is the 45-degree Kerrison punch. 3 mm. The first bite was at spinal laminar junction. And this is the inferior level or inferior lamina. As you know, this the ligamentum flavum is just attached at the border of the inferior lamina. And we need to cut very less amount of the bone from the inferiorly, but superiorly there is 5 to 6 mm bone sometime you have to cut. And this is the undercutting of the spinous process to pass the light of the opposite side to go to the opposite side. And this is here the cranial end. I am trying to push my patty, neuropatty, at the first I tried at the shoulder, then at the middle, because it was not able to negotiate and it was very tight canal. I was not able to negotiate my patty and it was too tight and it was very difficult to go to the opposite side. With the help of the Kerrison punch, I was just pushing my angle of Kerrison punch and pushing the dura and the neural structure a little bit anteriorly. Then I was able to negotiate my instrument at opposite side, undercutting of the bone. And this is the hypertrophic part of the ligamentum flavum of the opposite side. Almost we have reached now at the on the foramen level of the opposite side. This is the white glistening structure is the nerve root of the opposite side. This is the hypertrophic part of the this is the nerve root. It is almost decompressed up to the foramen, and this is the at the foramen level or de-roofing of the foramen with the help of the same Kerrison punch 45 degree, and this is the same side. I am just again cutting a little bit, sacrificing the bone at the medial aspect of the facet because it was overhanging. So pathological part of the facet, that is overhanging part, we have to remove. Otherwise, you cannot decompress completely the nerve root. So this is the almost de-roofing of the foramen of the same side and the hypertrophic part of the ligamentum flavum. The whole surgery I was doing with the same Kerrison punch without using that drill or a saver or anything. And this is the ligamentum flavum at the cranial side. Can you see what is that? At the midline. At the midline there is a rent in the dura. See this? That the dural fibers and also the neural tissue is coming through that rent. though it is very small, hardly 2 to 3 millimeter, then I was able to luckily to push that neural tissue inside the sac, and then I used a little bit of the muscle. Though the spinal needle is advisable here, it's better to push the muscle tissue to the dural sac. But I think that sister was taking little bit time to give me the spinal needle. That's why I was trying with my spatula or Penfield, and luckily I could do that. It is very small tear rent at the midline and the cranial end. So I was expecting and I was prepared for that. Maybe somewhere, maybe I will face this type of problem because it's too tight canal. Bone was very strong, and I was having no saver bore that time because it was unsterile. The previous surgery was something arthroscopy, and then over that muscle, I used that Surgicel. As it is a very small rent, and Dr. Rohit has shown you that how to stitch also with the cardiac stapler if it is a bigger rent, and there is a very thin layer of the gel foam I just over it. And my assistant at the end saw me, told me that why not you have checked the nerve root of the same side. That was the nerve root of the same side. Okay. Now that same patient, after 24 hours, I didn't ask the work for 24 hours. After 24 hours, very much comfortable, and he was walking. So how to tackle the epidural bleeding? Yes, Rohidas, you want to say something? Okay. So how to tackle the epidural bleeding? That we have the gadgets like bipolar cautery that is coming with the set, and also you saw that Surgicel sometimes also control the bleeding, and sometimes we are putting the patty and keep it for 20 seconds and wait, but don't put the more number of patties one over the other. That should not be. You may miss the patty in the inside, then you have to sometime convert to the open surgery. And last time there was a question about how to cut the annulus. There are three instruments you can use. The annulus, we have an annulotomy. We have an annulotomy. There is a rod like it there, but it is a hollowed one. There is a spike here, and also with the help of the Penfield retractor or 11 number blade also enough. We can use the 11 number blade with the blade handle that will go inside. Now another patient, this patient is also a doctor, is a surgeon, was walking for 4 kilometers with another 3 friends. Gradually his walking distance reduced, and then he contacted me and reduced less than 1 kilometer. He was almost taking a break and he was not able to go for morning walk with the other friends. And that was around, I think, 2009. And 2009 he met me, and then this was the situation. Mahinder, just tell me, this is the 3 level. Are you able to see all the 3 level? That is 3, 4, 4, 5, 5S1. I think the stenosis at the 3, 4, 4, 5 is almost grade 3 as per the CJAS, and the grade 2 at the L5S1. There's a complaint of the patient is bilateral lower limb weakness, and also the walking distance or claudication pain starts at less than 1 kilometer. Patient is about 64 years and is a surgeon doctor. Any other information you want? There is no neurological deficit. Mahinder, unmute. Mahinder, unmute.
What back pain he is complaining?
No back pain at all. Very rarely he told me that maybe years once or twice for 2 to 3 days. There is no more back pain.
Do you have his X-rays, LS spine?
Yeah, I missed that X-ray was there. I missed it. It is 2009. I missed that X-ray. X-ray was nothing. There was no spondylolisthesis. There is no sign, but there is a lot of weakness, degeneration, but there is no listhesis.
I think standard endoscopic spinal canal decompression will be my plan.
I'm asking about 2 level or 3 level.
Then I'm not able to see L5S1 clearly because your pictures are coming here. So, but these two levels which I am seeing is L4, 5 and 3, 4, I can surely, no doubt, 100% I'll go at both levels endoscopic canal decompression. L5, S1, I'm not able to see.
Okay. Just Rohidas, can you unmute? What are the precautions during surgery you like to have? You want to have your ultrasonic dissector or as an instrument, as a usual regular instrument is enough? Unmute please, Rohidas. Yes.
The basic thing is you are a surgeon, you have to prevent your all complications. Do anything.
And L4, L5 and L5S1 you like to have from single port?
Use any gadget, your complication rate has to be as low as possible. First thing. Then if you think that all the levels are culprit, target all the levels. If you are able to tackle 2 levels through same incision, it's best.
Okay, L4, L5 and L5S1, if you want to operate 3 level, 3, 4, 4, 5, 5S1, then 4, 5, 5S1 you want to tackle from the single port?
Yes.
Yes. So this is the beauty of this surgery, that you can, the same patient in 2007, 2009 we operated, and 2013 I invited him as a chief guest for the World Endoscopic Spine Society Congress in Bhubaneswar. And Dr. Destendu is here, Dr. Rohidas, Mahinder, everybody was here, I was here, and he's the patient. He was the patient in 2009 and now he was the chief guest for the inauguration of the session in 2013. So my question to Dr. Rohidas, can you unmute please? This is how much facet we should remove. This is the question everybody is asking everywhere when you are in the lumbar canal stenosis. How much facet you like to take and what is the end, where you will stop?
In my video I showed you, you should be able to see shoulder, axilla and the nerve root completely free going into the foramen. So you have to remove the facet till you see the complete root.
Both sides?
Both the sides. Opposite side you have to undercut it. Same side you have to.
And my next question, if there will be any breakage, if there is any breakage of the facet during the surgery, mostly it is the partial facet break or total facet breaks?
You have to be very careful. That's why I use drill. When you use Kerrison punch, there are chances that you will violate the facet.
Perfect. Because of this osteoporotic bone.
Yes.
But what I mark in my practice, I think there's an in Kerrison punch also, if it is backs at all, I think it is only unilateral and that too only partial. Never happens the full facet break.
If it is a partial one, ipsilateral, one side doesn't matter. The opposite facet will take care of the stability.
Okay, if there is a full facet break,
even only one side, it doesn't matter. If you have kept the opposite side facet intact, that helps a lot.
Okay, Mahinder, I have a question to you. Can you unmute, please? Unmute. This type of surgery, this type of patient when is a 2 to 3 level and you are taking the 3 level, all the 3 level, and definitely it takes about 1.5 to 2 hours of surgery by endoscopic technique. Sometime if there is a very tight canal and you want to go to the opposite side, not able to negotiate the instrument, sometime have you faced any breakage of the spinous process?
Yeah, very few instances, but nowadays when I face the way situation like you, I try to burr the bone over the flavum.
So you are keeping the flavum intact and going to opposite side.
I use flavum as a guard for dura because these are the cases where there is a very tight, there is a bony and soft tissue stenosis and you end up injuring the nerve root or a dura. So first I try to burr the bone, then I think the ligament of flavum relaxes. The moment you remove the burr, you can see the mobility of a flavum. Then bit by bit with a 2 millimeter Kerrison punch, or you can put in a small patty below to protect the dura further and you can proceed accordingly.
So if there will be any breakage of the spinous process, what you will do? Are you wearing that?
No, I just leave it. Nothing. No intervention. I just leave it without any intervention.
And that will change of the any post-op management of the patient.
I think these patients have never complained of even back pain.
Are you advising to use the belt or something?
No. Only if patient comes back to me कि सर मुझे पीठ दर्द बहुत हो रहा है, मेरा दर्द उठ के चला नहीं जा रहा, then I usually apply lumbosacral belt. Otherwise, no.
And even
I have never used lumbosacral belt after surgery in my practice.
Okay, it's very clear.
Huge financial loss to me.
Okay. So what is very clear from
You
our
calculate 5 to 6 belts a week for 27 years. You can calculate.
No, I'm asking for the breakage. If there will be
No,
any
nothing.
break.
It will heal.
No, for that I'm asking if you want to use for a month or 6 weeks for this belt or something.
No.
That is an individual call I shared with you. These spinous process fracture doesn't cause any problem to the patient. So why you should brace the back unnecessarily?
So this is another complication I faced in my practice, initial phase of practice. This is a question for Mukul. Mukul, can you unmute this? Just say me this is UBE, because what I got the message from your talk and what I experienced from the UBE, I have done some few cases of the UBE after my training. I was there with Dr. San in January, along with all our three, Dr. Rohidas and Dr. Mahinder. But I learned that is very precisely and very clearly you have mentioned there are two things. It is very good that going to the opposite side foramen, I think visualization is far better in UBE. And the another best advantage of the UBE that if you want to go to the fix, maybe in the maybe the discal space, you can directly put the telescope into the disc space, see very clearly, and also the end plate you remove very gently without disturbing the vascularity and all that. That you just very gently negotiate without any hammering or a sharp instrument, only blunt instrument you use, and remove both the end plates and then push the cage with the graft or something. So this is under vision, you can put the graft and you can go to the disc space. This is the two best things available with the UBE, which is I think better than any other technique. Now tell me, when you are going to this disc space and you are using very thin instruments, I break this is my disc space in the disc forceps in the disc space. Any of this type of complication have you faced?
Fortunately, not up till now, sir. But looking at these images, it looks to me that you were trying to go towards the opposite side disc from the same side, and I think the tip broke on the disc space on the opposite side.
Absolutely.
Do you know the reason of this?
Yeah, I don't know.
This is poor quality disc forceps.
No, this is Star's company only.
No.
This is Star's company.
Yes. Then you have rotated it.
Yes. So that was
my cause. You rotated it inside the disc space. That's why it has.
I rotated that, and it was my initial phase of practice. I rotated, and then it is pushed almost opposite side, and it broke. So I took the help of the C-arm, and with the help of the another disc forceps, I could manage to remove that.
Okay.
So that was
We'll go to Nilesh now for the question answers.
1 minute. So this is the last slide of my dural tear that I think we have already seen this. Another muscle I am putting, and this is the nerve root herniation, and also this is about 3 to 4 millimeter only, and we are putting a muscle page that in the dural sac, and then over that is that surgical. No need to any stitch or something. If it is a bigger, then you think about stitch. And the beauty of this surgery is that when you remove the tube, the whole muscle will fall inside. There will be no dead space. So there will be CSF leakage very less, and there is a healing chances almost 100%. There is very, very rare chance to go for pseudomeningeal seal or something. So this is spondylolisthesis we have discussed. You want to discuss more or just go for question answer?
We'll go for questions. Wait.
Very good. Okay, nice. Thank you.
Back to Nilesh. I'll just end this discussion. Stop sharing now.
Stop sharing. Okay.
Nilesh,
Nilesh,
I'm audible.
Nilesh. I'm audible. Yes, you're audible.
I'm audible. Yes, sir. This
One
question
minute.
comes from Dr. Ashish.
1 minute. Nilesh, 1 minute. We'll just summarize it. You are able to see the screen?
Yes, sir.
Okay? You are
Yes, sir,
able
I'm
to
able
see the screen?
Yes, sir.
Yeah. Just summarize canal decompression for a lumbar canal stenosis is one of the. Hello?
Yes, sir.
One of the best surgery because there are less chances of discitis, less chances of instability, simple canal stenosis.
Rohidas, your slide is not visible. I think you have to go for a slideshow or something.
No, it is not visible.
Yeah, it is all the
Only your
slides.
screen is visible, but slide is not getting.
All
Then
the
it's
slides.
okay. I will stop it. Then it's okay. Yeah, then it's okay. Yeah.
Okay, then Nilesh, you take over.
Nilesh.
Yes, sir. Right now we are going for a question answer session. The first question comes from Dr. Ashish, who is from MP, and he's asking Estendo technique and UBA technique, which is the best to adopt first for a newcomer?
Yes. I think Mohinder can answer. Mohinder, unmute, please. Yes.
Let Mohinder answer first.
And Dr. Rohidas, sir, both you can give your opinion.
Yeah, let Mohinder first, then Rohidas. Yes.
This guy is a neurosurgeon or an orthopedic surgeon? The doctor who is asking question, is he ortho or a neurosurgeon?
Sir, he has not mentioned his neurosurgeon or orthopedic.
So now I'll try to I will try to answer from neurosurgeon's angle also and orthopedic surgeon's angle also. A neurosurgeon, I think with eyes closed, you should go in for a Destendue. UB will be difficult for him to learn, number one. And if guy is an orthopedic spine surgeon with some knowledge of arthroscopic surgery, I think he will be well off with even UB also if he wants to pick up one. Because if he picks up Destendue, he should carry on journey with Destendue. There is no need to change over to UB either. He should keep going with the Destendue, his surgical practice, or UB. I mean, both the techniques meet the same requirements. There are no limitation with one technique. This you can do with Destendue, this you can do with UB. So he has to pick and master one technique. So if he is a neurosurgeon, and I think Destendue will be a better option for him. But still, since UB is now have certain extended indications, so after he learns with Destendue technique, he can switch over to UB. But UB learning is triangulation is little longer than difficult as compared to Destendue.
Rohidas.
UB is little more difficult because you are using one hand. Instrument in the right hand, scope in the left hand. So you are using actually one hand. If you are used to two-hand technique in open surgery and everywhere, it becomes a little bit difficult initially. And suppose in the initial stages you damage the scope, then you change the system. So better to start with something which is less, which is easier, less difficult. So UB, you can stage it and do it afterwards.
Can I add this something, Nilesh?
Yes, sir.
Yeah, can I add something here in this question?
Yes, always welcome, sir.
Yeah, this is as per my knowledge concerned, as I have done UB also some cases, and I'm though for last 13-14 years I'm doing this endospine, the Destendue technique. For me, I think UBE is little better for only one or two indications if you are going for the fixation, and also the same instrument. Because if you are an arthroscopic surgeon, if you are an orthopedic surgeon, arthroscopic surgeon, the same instrument, no need to purchase any instrument, you can start with straight away. But learning as per both the Dr. Rohidas and Mohinder, as per both of them, that learning will be little bit difficult, though son himself is a neurosurgeon and he is doing that technique. So learning is a little bit difficult and also time taking. If you want to operate 4 level by Destendue technique, it takes about 1.5 to 4 hours, 2 hours. But if you go for UBE, it will take about 4 hours. So I think Destendue is easy learning, surgeon friendly, and you can learn faster and you can use everywhere. Only in few cases If you are expert already, you want to fix it with the endoscope, then you think about the UV.
And sir, Dr. Mukul's any opinion regarding?
I completely agree with PC Day, sir. Because the investment involved in UV is relatively more. Learning curve is more steeper as your both hands are working independent of each other, stabilizing the scope and also simultaneously controlling the instrument in the opposite hand. That takes quite a long time. And the problem with the scope is even if you're using a 0-degree scope, if you rotate the scope, the image distorts. So keeping yourself oriented, also triangulated at the same time while working in such a close field of vision, it takes time. Probably it is better that if one is starting out in endoscopy, start with a Distendo system or an endospine system. Once you've completed your decompression and your job, make another small stab incision at the side of your tube. Try to put in your scope from that and remove your endospine tube and try to triangulate after you have done your procedure, just for like 10 to 15 minutes. That way you are going to get a more better hang, and obviously practice outside on your bone models.
Yes, next question.
Sir, next question is on how you are doing multi-level disc surgery. Are you doing in a single setting or a stage setting? More than two level if you want to do.
I think we are regularly doing 3-4 level. 3-level disc we are doing. I have 3-4 cases of 3-level disc. I think 4 level also we have started stenosis. Dr. Rohidas also operated few cases of 4-level stenosis. And this year I have operated 3 cases of 4-level stenosis. So 3-level, 4-level does not matter. It takes about 25 to 30 minutes for a single level. And if you are doing a regular or this endospine regularly in your OT, your assistants, your sisters, your anesthetist, and positioning, etc., hardly takes about 15 to 20 minutes. And after that, if one level are 25 to 30 minutes, you can go to the opposite side and decompress, and also to 2-level 455S1 from the single port. So without wasting your time from the approach, you can approach also 455S1 from single port. So 1 hour and another 2-level, another 1 hour. So there is no much difference because it is all interlaminar approach and that posterior approach. So surgeon friendly technique, and both the hand of the surgeons are free, and you are using the instruments, not that saver or something. That instrument is only 3 millimeter. You can cut as much as required, as much very easily and very fast without any problem.
Can I add something to that?
Yes.
Probably initially when you are learning, it is better to stage it, I guess.
Initially, just Mukul, I just add to initial phase. Always you start with a single level disc and that unilateral, and never think about the stenosis from first case. Maybe after 20-30 cases over the learning curve, you think about stenosis. Single level left side disc is the best, L4, L5. L4, L5 left side disc to start with, single level left side disc is better.
Okay, I think if the surgeon has done less than 100 cases and he has got 3-level stenosis, patient has walked in with a 3-level stenosis, it is better to stage. I think Dr. PC Day has shared experience of a master surgeon who has done close to 1000 plus cases. A guy who has just done 50 to 100 cases, he should ideally stage the procedure, and that's number one. Or he should be mentally prepared to finish the job in about 3 hours time. If these are 2 levels, but if it is more than 2 levels and guy has just done 50 to 100 cases, it is sensible he should do it in a stage way rather than if he is not able to complete the procedure in one go. But guys who are done more than 500 cases, they can comfortably do 2, 3, 4 levels in one sitting.
Fine. Okay. Any other question, Nilesh?
Sir, this question from my side. What are the indication for endoscopic biopsy?
Yeah, indication biopsy. This recently I did 2 cases. One is the sacroiliac joint, and there is a L5S1 to sacroiliac joint, there is a tuberculosis. And then another was L5S1, there was a cyst-like thing at upper end of the sacrum, that ala of the sacrum, there was a cyst. So these are the things you can take the biopsy. I have no much experience on this. Rohidas can add it.
Dr. Mohinder sir or Dr.
You
Rohidas sir,
can use this technique, endoscope, for biopsy, tuberculosis, any other thing. There is not much difference. Just like a routine biopsy, you can take a biopsy.
I think
first patient, I did the biopsy. I thought that was a tuberculosis. That CT scan, everything was guiding me as a tuberculosis. Patient have only 1 month history and 64 years, but that came out as a CA, cancer. And primary was found out from the prostate.
Yeah.
Dr. Mohinder sir, you can add your comment on this.
Biopsy. Any other indication for the biopsy?
Indications means any suspicious is in the spine, wherever it is, you can that place with the help of endoscope, and whether it is a malignancy or whether it is some kind of infective pathology or vice versa. So it aids. You can use this as a spinal endoscopic biopsy tool rather than going in for a open bone biopsy.
I think you can simultaneously decompress also.
Yes,
so
this is
2 birds with 1 stone.
Yes.
This is what recently I did a case that was a suspected case. We thought it is Carey's spine. It landed up with the myelopathy, paraparesis. And when we did the decompression to the biopsy, it turned out to be a plasmacytoma. So then we have to stop ATT and refer him to our onco friend.
This is my next question from my side. Which bone graft you are using with endoscopic fusion? Is it artificial or autologous bone graft?
You see, I mix with the autologous chips. We use decalcified bone matrix. It is a bovine bone most of the time. And there are 1 or 2. I use bone graft from Zimmer. Then there is one Korean company. I have used bone graft from Indian company also. I think the Surgical company, they also market this demineralized bone matrix. So I have used graft from these companies and they reasonably do well. I think there is nothing wrong with the graft. The technique has to be correct.
Autologous bone graft you are using?
I mix it with the artificial bone graft and then put them into the disc space for fusion.
Nice. And last question. How to deal with post-operative disc infection after endoscopic surgery? There are very few chances or less chances of post-surgery infection.
I think post-surgical discectomy after endoscopy is really a nightmare for a patient and for a surgeon alike, because these patients go very happily back home, and on 5th or 6th day you get a distress call from these patients that they have got so much of severe back pain that they're not able to get up and walk. So such cases, I immediately call them to the hospital, do initial blood workup, order a fresh MRI that give you rough idea that he may be developing an infection, and I start IV antibiotics. And in all my cases, I think I keep them on 2 weeks IV antibiotics and next 4 week oral medication, and most of them have done very well without any further complications. And back pain also settles down in these cases by end of 2 weeks.
Dr. Rohidas sir, can you comment on this?
Discitis incidence is very less because the instruments are not touching the skin. In discitis, there are 2 major organisms, Staphylococcus aureus and Pseudomonas. They are from skin. As the tip of the instruments are not touching the skin, there are very less chances. If unfortunately there is a disc infection, IV fluids, bed rest helps them because we have not aggressively tackled the muscle tissue and other things. So as the approach-related trauma is very less, the discitis settle down with bed rest and antibiotics, aggressive antibiotics.
How many days antibiotic you would preserve? You prescribe how many days of antibiotics, Rohidas?
6 weeks.
And IV antibiotics?
6 weeks of IV antibiotics or 6 weeks of IV antibiotics?
No, if the patient is local, IV antibiotics. If the patient is from outside, 2 weeks of IV and then oral.
I have a question to Dr. Rohidas. Can I ask? Nilesh, can I ask to Dr. Rohidas?
Yes, sir. Yes, sir. Yes, sir.
So, I think Dr. Rohidas has presented his paper about more than 50 cases of the grade 1 spondylolisthesis, and he just decompressed and left, and he is also following very regularly to all those patients. How many patients shifted to grade 1 to grade 2 and need surgery, or grade 3 like this?
Only one patient of mine where there was problem, he needed fixation afterwards. Otherwise, no.
Any comment on this, Mohinder? Dr. Mohinder, can you unmute? Mohinder. Unmute, Mohinder.
I think some patients whom I decompressed, retrospectively when they keep coming to me, and keep telling कि sir back pain बहुत तंग कर रही है, आपने जो दिक्कत थी वो leg symptoms have settled. Retrospectively, I think maybe I should have used those patients. But having said that, I mean nowadays I do a very clear-cut counseling with the patient. Patient has to decide whether he has a back pain also interfering with his daily activities. Then I tell them I consider fusion also. Having said that, still my 90% of patients are the one where there is I am not fusing them. Only 5% or 10% patients where I am giving them an option of fusion. And I think these patients I am so very happy. Now I have a follow-up 5 years of post fusion. There is no adjacent segment disease, and these patients are very much relieved of back pain. That is what I was surprised with endoscopic MIS fusion. No adjacent segment disease, good relief of back pain, and they are able to do all their household work. I mean, now I have a 5 years data, although very small number of cases, but all my patients are very happy, and this is a great motivation for me. This is a good procedure provided you rightly select a patient. You can't oversell this MIS fusion technique to the patient. Every patient of stenosis surely doesn't need a fusion.
Any time you have tried for stage 2 or grade 2 listhesis?
Yeah, only in stage 1 or stage 2 listhesis I do fusion, and if it is
I'm asking stage 2 listhesis only decompression without fusion.
If it is a stable slip and patient doesn't have much of a back pain, I don't do anything to the slip. I just do a decompression and that's it. I have done decompression in even stage 3. These stage 3 patients are pretty.
What are the criteria for your this stability unstable spine?
I simply take dynamic X-rays, dynamic views of the spine. If there is abnormal mobility, the lumbar excursion which is more than around 4 millimeter, I tell the patient that there is a problem and you take a call. And in grade 3 cases, usually I may put in an intertransverse graft rather than putting in an interlaminar graft. Stage 1 and 2 in a standard manner, the way Dr. Sohn was doing fusion, same way I am doing.
Mahinder, just I have a question of the patient. If the patient is having the osteoporosis and you suspect the osteoporosis, are you doing the BMD before the surgery or fixation?
I think majority of my patients, since we have a osteoporosis center in our hospital, so all those patients who are post-menopausal, 60 years plus, and they are coming for this kind of decompression, they are evaluated for osteoporosis also. That is, I mean, most of the patients are evaluated, and I have seen these osteoporotic patients, if you don't address osteoporosis, these patients do complain of back pain post-endoscopy.
Rohidas, are you prescribing any osteoporosis medicine for the post-surgery patients? If anybody is having doubt of the osteoporosis or any degenerative spine more than 60 years, 65 years, and you are suspecting something.
Every patient of spine, you have to think that he is having vitamin B12 deficiency and vitamin D deficiency. So all my patients after the surgery, they are on all these things. For the backache, they are advised muscle strengthening exercises. So the backache problem is over if they do good amount of muscle strengthening exercises. If their back is flexible, the backache is gone. So I don't believe in this thing. This is a routine protocol for each and every patient. I tell my patients till he goes to the Smashan Bhumi, he has to take these 2 multivitamins. Because these are the treatable nutritional deficiencies we have in all our patients.
Multivitamins and?
Vitamin B12 and vitamin D.
That's all. And you are not giving any osteoporotic medicines?
No, if they take this regularly, and I advise them to sit in sunlight, early morning sun.
So
that is the only natural resource we have not contaminated.
Vitamin B12 and vitamin D you are giving. In vitamin D, what a regular practice we are giving that weekly once 60 lakhs units, 60,000 units weekly once.
Surgery 60,000 once a week for 2 months and 2,000 international units per day till his death.
Okay. So in that way you are prescribing. Okay. Because sometimes we are prescribing maybe monthly once, 60,000 unit monthly once. You are prescribing 2,000 every day. Okay. The same thing. Any other question, Nilesh?
No, sir. Right now we are over with the question. So I will hand this session to Dr. Rohidas sir for his remarks.
I will have a closing remark. Now, we had this session about lumbar canal decomposition. For the endoscopic thing, open or microscopic, when you compare the discectomy, they think that it's the same procedure when we are tackling the disc. But when we tackle the canal stenosis, the endoscopy has an edge over the microscopic or open technique because we are reducing the trauma. We keep the spinous process and the opposite muscle attachment with the facet intact. Opposite facet is undercut. So it takes over, it is an edge over the open technique or microscopic technique when we use an endoscope. Now the philosophy changes. When I started this in 2004, I was little afraid of using drill. So I thought of a drill with a protection sheath. Then I thought of a ultrasonic bone dissector. But when the visualization became better, with a 3D, I am able to see the space, magnified space between the lamina and the opposite facet, the ligamentum flammum and the opposite facet. So I can see that space. So nowadays I am more aggressive with the drill rather than using a ultrasonic bone dissector. So these changes occur as the technology develops and you catch over with the new technology. So we will end this session. Back to Nilesh now.
Back to Deepak.
Yeah. Thank you very much. On behalf of Health and You, I would like to thank Dr. Rohidas for putting this episode 2 together. It was a wonderful session, very, very informative and educative. I would also like to thank Dr. Mohinder, Dr. P.C. Day, and young and dynamic orthosurgeon Dr. Mukul for their wonderful discussion and display of technique. I am sure, audience, you must have found this the entire discussion very, very interesting and enlightening. We wish to thank the audience also for joining this webinar, taking their valuable time from their families. We request your support for Health and You products. Thank you very much, doctors, for taking care of Indians in this COVID-19 tragedy. Stay safe, stay healthy. And this is Deepak Naik signing off on behalf of Health and You, always together with you. Thank you.
Nilesh will announce the next course date and.
Great, that'd be nice. That'd be nice. We would love to have that. Yes, Nilesh, Dr. Nilesh.
Unmute Nilesh. Nilesh, unmute. Yes.
We have the next webinar on the same endoscopic spine surgery distensive technique, and the topic of the discussion was a posterior and anterior cervical approach for a discectomy called decompression, which will be on next Sunday. Time we will be announced soon.
Timing we will announce, and we will try to see Dr. Ortal if he can join us. He is the founder of the Easy Ecosystem.
That will be great. Then it will be international webinar.
Because there is a lot of work he has to do in his department because of this COVID in Germany. So he was a little busy. Let's see. He has told that he will be able to join. We'll see. Yeah. Thank you.
Thank you, Dr. Nilesh, for your wonderful coordination.
Thank you.
Yeah.
Thank you, sir, and
Great. Thank you.
happy Akshaya Day to everybody, and happy Ramzan.
Yeah, absolutely.
Yeah.
Thank you.
See you, Deepak, Nilesh.
Thank you. It was
See
great.
you. Bye-bye.
Bye, sir. We are signing out, sir.
Yes, yes.
Yes.
Okay,
Thank you,
thank you,
audience.
sir.
Come back again. Audience, come back again. Thank you.